All right. Well, good afternoon or good morning to everybody from the various time zones of the world. Welcome to our next monthly cybersecurity seminar. This is the UCSF-Stanford CERSI FDA Distinguished Speaker Series for Cybersecurity for Biomedical Engineering. I'm your host and moderator, Professor Kevin Fu from Northeastern University, and it's my pleasure to host this event today with our distinguished speaker. A couple reminders before we get into the content of today's seminar. This seminar does not represent official FDA policy or HHS policy guidance. The contents are those of the speakers and do not necessarily represent the official views of nor an endorsement by FDA, HHS, or the US government. This seminar is being recorded. A little bit about me. If you've been coming regularly, you probably know that I'm at Northeastern University, and I was previously acting director of medical device security at the FDA, and I presently direct the Archimedes Center for Healthcare and Medical Device Cybersecurity. A couple of announcements before we get in. FDA is hiring. FDA is looking for cybersecurity staff. You can contact Diane Mitchell if you're interested, and you can learn a lot more about those opportunities for both the post-market and the pre-market, both technical and non-technical work to protect and make sure medical devices remain safe and effective despite cybersecurity risks. Also an announcement that after this, there's a second set of discussions over in the Archimedes Circle. If you want to join that, that'll be more interactive with a group of panelists. You can hop on over to secure-medicine.org/events, and you can find today's Zoom link for the follow-up discussion on cybersecurity performance goals in you. Okay, so why do we have this seminar series? Why are we here today? Unless you're living under a rock, right? Malware, ransomware, computer security threats have been affecting the availability and the integrity and the confidentiality of healthcare delivery. Just this month, just in the last few days and weeks, I would imagine many of you have heard about the challenges at Change Healthcare and United Health Group and their Optum Solutions Group, which was allegedly hit by ransomware, bringing down a lot of their cloud services. And so you can find many of these articles on the New York Times, and now even a criminal investigation has been launched into the attack. It's really important to realize this shift from pure confidentiality thinking, things like HIPAA breaches. And now, over the last decade, we've really moved toward this more availability and integrity-focused security. So the two other security properties are beginning to become much more elevated, and that requires a change in thinking for both engineering and public policy. So what's going on to try to protect this from a government perspective? From the headlines, you can see many of you are aware of the Patch Act that was introduced to require things like software bill of materials for medical devices under FDA pre-market review. And just a couple days ago, in fact, FDA published its draft guidance on how it's going to meet this statutory requirement where they are required to receive these SBOMs and other information from medical device manufacturers to ensure the security of medical devices. FDA also released last year the final version of what's known as its pre-market, what I would consider the engineering guidance. What are the expectations when you submit a medical device for a review, whether it's a 510K or PMA or whatnot? What are the reviewers going to be expecting to see in there? Everything from the threat modeling and the pen testing to the SBOMs. And so I encourage you to read that document because it is now final guidance, which means it represents FDA thinking. We've had a number of past distinguished speakers on the program, everything from technical to public policy. And today we're going to focus on the cybersecurity side of HHS as an entire umbrella, not just the FDA lens, but the entire enterprise within the Health and Human Services. And so there's a very interesting website, hphcyber.hhs.gov. You can go to that. It's related to the 405D process as well. And one of the things I think is on top of mind today is the White House released its budget request, its annual budget request, and inside the fiscal year 25 request, you can see there's a $1.3 billion Medicare incentive program. And it's very interesting because it specifically cites this program is to encourage hospitals to adopt essential and enhanced cybersecurity practices. And so if you hop on over to the HPH Cyber website, you can see, coincidentally, two lists of essential and enhanced goals. And so I think we'll probably be getting into the discussion of what are these essential and enhanced goals today. If you want to know my thoughts, you can hop on over to my blog listed down there at the bottom. So it's my pleasure to introduce today's speaker, Brian Mazanec. Dr. Mazanec is the Deputy Director within HHS for the Office of Preparedness within the Administration for Strategic Preparedness and Response. We like to call it ASPR. I would say you can think of it as the top level go-between HHS and other entities when it comes to any kind of preparedness or response, including cybersecurity and hurricanes. But today our fireside chat is going to be about strengthening cybersecurity of the healthcare and public health sector and keeping patients safe. Dr. Mazanec has had a long and distinguished careers leading all sorts of aspects. We're not just talking about cybersecurity, but disease outbreaks, potential risks from nuclear weapons. And it's my pleasure to have him today on the program. And he's going to give a presentation followed by a fireside chat. So I'll stop my presentation now, Brian. And thank you again for coming to the program.
Great. Yeah, thank you so much, Kevin, for the invitation. Happy to be here. Let me pull my slides up real quick. Excellent. Great. And I also thank you, Kevin, for noting in referencing the president's budget request and the 1.3 billion for CMS and then connecting it to our CPGs. I'm glad you're seeing coherence between some of what we're doing, because we are, and I'll get into this in much more detail, but we are absolutely trying to use all the levers that the department has to really rise to the increasing cyber challenges that I'll talk about in a moment. So again, great to be with you all. Before I jump into focusing on that and really talking holistically about really at a strategy and policy level where the department's going to try to drive improvements in cybersecurity in the healthcare and public health sector, I did want to just briefly talk about the ongoing Change Healthcare cyber attack. You showed a number of headline clips. This has been the largest cyber attack against the healthcare sector in American history, and certainly has been an all hands on deck moment for the department. So I felt like I'd be remiss if I didn't kind of address that a little bit right up front. This is something that the department has recognized right away has a major impact on healthcare operations across the country. HHS and ASPR as part of the team here, which again, I'll get into in more detail, has acted with that sense of urgency. Our first priority, as it is with any cyber attack, is to help coordinate efforts to really avoid or minimize disruptions to care throughout the healthcare ecosystem. With Change Healthcare, which is owned by United Health Group, the issue really has been that they manage the back end of healthcare technology related to processing claims, billing, prior authorizations, and more. They process something along the lines of 15 billion healthcare transactions annually, and are involved in 1 in every 3 billing or claims records. So massive connectivity as a third party kind of across the healthcare ecosystem. So this has been an attack that really exposed that systemic risk. And it's a terrible attack, but in the sense, it's a good backdrop that illustrates the importance of all the things the department's doing that I'll get into in a little more detail. But specific to the Change Healthcare attack and to help you understand ASPR's role as well, and this gets to Kevin's comments up front, we are kind of like the response Swiss Army knife for the department in many ways. And it is an emergency response organization. And from day one, when we learned about this attack on February 21st, which is the same day Optum and United Health Group and Change Healthcare, all interconnected entities, learned about the attack, we got to work, ASPR and the department. We stood up interagency coordination with our internal U.S. government interagency incident response team. We leveraged our regional offices and external stakeholder relationships to monitor, assess patient impacts. We began doing leadership to leadership at the CEO level, calls with United Health. We also talked to a number of impacted hospitals and providers across the country and are continuing to do many of these things And in those interactions, in addition to obtaining, which we do for any cyber incident, significant cyber incident, obtaining information to help us understand impacts, we've been urging the private sector, particularly the payers, the clearinghouses and such, to be as transparent and helpful as possible in helping providers mitigate the impacts of this incident. So this has been, again, an all hands on deck moment, a really significant attack that illustrates the importance of everything I'm going to talk about in more detail in a moment. So just wanted to acknowledge that up front. And maybe as one more data point on that, and then I'll dive into the what I'm really here to talk to you about today. The secretary announced in a hearing just yesterday, just to illustrate the magnitude of the department's efforts, that CMS has pumped into the healthcare system to kind of navigate this attack and mitigate impacts, something along the lines of $2.7 billion since this attack began on February 21st. So that's kind of the volume of what we're having how we're stepping up to the plate along with industry to deal with this one. So it's a big attack. So what am I actually here to talk to you about today? So I want to just give a little context, explain a little more about ASPR's role that I just alluded to in all of this and why I'm here. But then really dive into the concept paper that the department rolled out in December, which is essentially, we call it a concept paper, a strategy. It's short, 6-page document, and I'll go into more detail on it, but really lays out where we're going. One of the elements in that is the CPGs that Kevin mentioned that we published now in January, so I want to talk about those. I did also want to highlight one new tool that ASPR has recently rolled out that's helpful, hopefully, for cyber as well as other all hazards. That's the risk tool, the risk identification site criticality tool, and then hopefully leave a little time for a discussion, a Q&A. So in terms of the challenge, I probably don't need this slide based on what I just shared. And I think you all maybe are quite familiar with this already, or you wouldn't be here. But the challenge for the healthcare and public health sector, which is one of 16 critical infrastructure sectors as identified in law and in Presidential Policy Directive 21, it has seen significant increase in the sophistication, the intensity, the volume of malign cyber activity, cyber attacks. There's a lot of reasons why this is the case. Medical device, cybersecurity, legacy devices, definitely part of that, and a challenge that, as Kevin mentioned, my colleagues at FDA are working every day to address. It's also a chronically underfunded activity within healthcare where there are already very, very narrow margins. There are a lot of facilities that are, especially after the pandemic, are barely able to make their payroll. The margins are so tight. So investing in cybersecurity is particularly difficult. So we've seen this, you can see the numbers there, a 278% increase in large breaches. We're seeing that increasing sophistication of the attacks. And again, the Change Healthcare attack is an example of that from a systemic risk third-party perspective. A report just to mention on the costs associated with it, I saw an industry report a couple months ago that was looking at what the victims of ransomware paid, the ransomware payments year over year. And for 2023, they had estimated that it was $1.1 billion in payments. That's just the payments to the ransomware actors, not all the other costs associated with these attacks. And that was in 2023. Their number for 2022 was 567 million. So just astronomical increase in the threat here. So what's ASPR's role? What's HHS's role before I jump into some of these things that we're doing? So we serve as the Sector Risk Management Agency, the SRMA, for the healthcare public health sector, which again is one of 16 critical infrastructure sectors. There are other agencies like the Department of Energy for the energy critical infrastructure sector that serves as an SRMA, but about half of those 16 critical infrastructure sectors, CISA actually serves as the SRMA. So it's an interesting kind of approach where there's some variability in how agencies are aligned here. But we are responsible as the SRMA for the healthcare public health sector. There's 6 core responsibilities. These are codified in law for the SRMA. I won't go into great detail on all of them, but we're helping the sector focus on risk management. Again, in the context of the Change Healthcare attack, this is taking on probably in the near term some renewed importance to look at that systemic risk issue and where we may have more systemic risk in the sector. We support incident management. That's why everything I walked through and what we're doing with Change is a good example of how we lead the department's efforts on incident management, responding to cyber attacks. We're tracking roughly a half dozen or so fairly significant ransomware attacks in a given week, and have a whole process that we use to, in a cyber incident response plan that we use to manage that. The FBI is the federal government's lead for responding to cyber attacks. So FBI and CISA are both key partners in incident response. We aren't always the ones right out front, but we play a key role and coordinate very, very closely with them. We facilitate information sharing. And as an example, in the Change incident, when we got some indicators of compromise, some threat intelligence information that we thought was relevant in the context of the attack, we push it out through a bulletin and various channels. So communicating that with the sector. I'll talk more about that sector coordination piece too. That takes a lot of our energy and is a big part of this. But just wanted to give that framing. This is the SRMA role that ASPR plays, and it's a big partnership role with the sector. And just to kind of touch on that briefly, we work closely, and every SRMA has this kind of umbrella, but we work closely. We facilitate the Government Coordinating Council, so that's where a number of government entities within HHS and outside of HHS, like the Defense Health Agency and others who play a role in the healthcare public health sector, are engaged. And then the Sector Coordinating Council is where we have over 400 private sector organizations who voluntarily participate and collaborate with us on the development of best practices, focusing our efforts. So partnership coordination is a major aspect of the SRMA role. A lot of what we do, we couldn't do without that tight partnership with industry. Just framing too, I wanted to make this point whenever we're talking here about cybersecurity, that's critical. It's the elephant in the room for, I think, every SRMA right now, but it is an all hazards responsibility. So I really wanted to foot stomp that. Our focus is on all hazards. Again, cyber is consuming most, and appropriately so, most of our activities to date, but we do look at other supply chain disruptions, hurricanes, and tropical storm. Those things you see here are other hazards to the healthcare public health sector that we are focused on. But cyber is the one that consumes a lot of the energy. These numbers are actually a little bit dated. They're from just 2022. They've increased significantly since then. But just to show you some of the things that we do here, focus specifically on cyber from a couple years back. We also have focused on here some of the priorities, and this is a little bit dated from 2022, but just showing, and this informs some of what I'll get into in a moment, but particularly that minimum standards piece, like some confusion in the sector, some lack of clarity on what are the minimum standards that folks should be adhering to, some challenges with information sharing. So I won't go, just in the interest of time, I won't go deeper here. I'll get kind of right into where we are going now. So I've teased this, and Kevin, jump in if you have questions too as I go. But I teased this a little bit earlier, but in December, based on a lot of reflection and partnership with industry and some, we work closely with CISA and others who have data. We did our own landscape analysis as well, using a kind of rigorous methodology to collect some, not statistically representative, but we thought still helpful, kind of anecdotally representative data from various pockets within the sector to understand where things are at, and doing all that environmental sort of diagnostic scanning. We developed this concept paper, which it really is to get at kind of 4 key areas. And these are challenges we had known existed, we were working on, but we wanted to sort of do it in a coherent and holistic way. Those challenges, and you'll see the 4 pillars in a moment, are aligned to these challenges, is that need that I already alluded to harmonize cybersecurity standards. There was confusion over which standards to follow. So is it CISA's cross-sector CPGs? Is it the health industry cybersecurity practices we put out? A lot of need to kind of clarify and simplify there, especially given that hospitals, healthcare organizations, again, have those really tight margins, don't have a lot of time and energy and resources to sort through that. We also need to support the sector financially. Hospitals, particularly those critical access hospitals and others, as I mentioned, don't have a strong enough balance sheet to make some of these investments. So we recognize we needed to do more there. That's what Kevin alluded to earlier in the president's budget that was just recently released. There's a $1.3 billion request to do exactly that. So we're hopeful our congressional partners will support us in that. We also recognize we need to strengthen accountability. So it's great to have these standards, these practices, but we also need to have accountability from our Office of Civil Rights, from a HIPAA security rule enforcement perspective, but also in other ways. And then finally, just continuing to improve coordination. There's too many doors in the department to cybersecurity, as well as across the federal government. And there's not a lot of time when you're dealing with an incident to sort through that. So we're trying to create a one-stop shop within HHS to coordinate these things. So I just articulated kind of the 4 things our analysis indicated we needed to address. So this concept paper lays out 4 pillars that are aligned to fixing those. So the development of voluntary cybersecurity performance goals for our sector, so sector-specific goals, developing and administering incentives and resources to implement these best practices, increasing that enforcement and accountability, and then really building out ASPR as the one-stop shop for healthcare cybersecurity. And on the president's budget piece, again, $1.3 billion for that second pillar. On the last one, we asked for a very modest $12 million for ASPR that will help us build that out. So I'm hoping in the grand scheme of those numbers that we, again, we get the support of our friends in Congress. So I'm going to talk a little more about the cybersecurity performance goals. We call them CPGs, so sorry for the acronym soup, but HPH CPGs. We are the first sector to have sector-specific cybersecurity performance goals, so we're very proud of that. CISA is working with other SRMAs to develop something similar, but we publish these at the end of January, and a lot of what we're going to be doing going forward is going to be focused on driving implementation and helping develop sort of supplementary resources and tools to help entities across the sector really embrace these cybersecurity performance goals. So I mentioned this already. I won't belabor this slide, but there's existing resources, which are all very helpful, very valuable, continue to be valuable, but confusion over what to look to across the sector. And this was again, one of the key drivers behind the development of our HPH CPGs. We did on the health industry cybersecurity practices. If you're not familiar with that key document, this is the second iteration of it, which we published, I think, and we, the department, published in, I think it was late or mid 2023, so not too long ago. This is a marquee document developed with industry under the department's 405D program, which is run out of the Office of the Chief Information Officer. It's a great resource and tool. And we were very intentional when we developed the CPGs to actually map. If you look at the CPG document, excuse me, we mapped the CPG goals and to specifically we call this the HICCUP, again, another acronym, the Health Industry Cybersecurity Practices. So we mapped to the HICCUP. We also mapped to some NIST guidance to further help demystify. So you go to the CPGs, but if you've already done some work with HICCUP or the CISO's done work with some of the NIST cybersecurity framework, you're able to kind of see how it's all connected in a coherent and hopefully pretty easy way. And I've already talked to some of this, but I think this was intended to put that baseline practices out there. We're going to use it. There's that coherence across those 4 pillars. So we're going to be using these pending congressional support as we drive incentives. They're going to be oriented around implementation of the CPGs to the extent we have accountability mechanisms as well that we use and flesh out. We will be using the CPGs for that purpose too, going forward.
So Brian, actually, in the second bullet there in the benefits, the improved cyber resilience is really interesting to me. So let the audience know, you and I were at the White House last year as part of the PCAS working group on cyber physical system resilience, how to build in resilience rather than just the singular property of privacy. How do we make sure things are highly available, resilient to threats? And I think it's really hard to move away from sort of the perimeter-based, sort of pure firewall thinking into this mode of, hey, how can we have graceful failures, or how can we ensure we don't have a catastrophic system-wide failure like all of Change Healthcare going down if ransomware gets in? And so I think it's really interesting to see this in here because much of the earlier guidance has been much more focused on a very important property of privacy and confidentiality, but it's great to see some of the discussion of how do we actually get to the even more rigorous metrics of resiliency.
Yeah, great point, Kevin. And I'll get in a moment. Well, I'll give at least a high level preview of the essential goals, and you'll see a couple in both. And I'll talk about this in a minute. We broke them into two buckets, which I'll speak to in a second. But in both of those buckets, we have goals that really aren't about that perimeter defense. They're not about preventing, because you can't prevent all cyber incidents. We're going to have these attacks. You need to build in that resilience to be able to respond and recover more rapidly. So exactly, we designed these with that in mind. And that's all oriented, sort of the animating principle for us with the healthcare public health sector. Obviously, it's critically important to protect PII, PHI. That's hugely important for us. But the most acute and concerning attacks are those that threaten patient health and safety and really pose potentially risk of loss of life or urgent patient care. And that resilience is key there, because you're going to have to be able to adapt and continue to provide care in a variety of scenarios if you are subject to one of these attacks. So great point. I think I hit on most of this already. We're really trying to simplify things, trying to leverage what CISA has done, great work working with them and others. So I'll go into a little more detail on the CPGs. I also should note too, when we rolled these out at the end of January, and you previewed this, Kevin, up front, we did also roll out a new gateway website, and that's also part of our efforts to establish that one-stop shop for HHS cyber. And that's intended, we really initially it was built, and still, if you go to it now today, it's all built around the CPGs, but we intend to build that gateway out. It's not going to be the one place where everything across the department exists, but it should be that front door that you can go to. You don't have to worry about a bunch of different links and locations, and it'll get you to where you need to go. If you're interested in medical device cybersecurity, need to get to some of the guidance and resources FDA has put out, you can go to that site and it will get you to the right place. We will build out other tools and resources too that will hang on it. So it's very much, we're iterating on it now, but we did roll that out concurrent with the CPGs. In terms of the CPGs, they include, and you can see on this slide, they include both essential goals that outline that sort of minimum foundational practice for cybersecurity performance, as well as enhanced goals to encourage the adoption for of more advanced practices for those better, larger, more well-resourced entities within the sector. And the healthcare public health sector, with all of its subsectors, is incredibly diverse. It includes not just the healthcare delivery organizations, but the whole backbone, medical devices, so many different facets. So we thought by designing these in a way where there's essential and enhanced, that'll make this a more useful tool to really get at different points of weakness and start wherever you're at. Because we recognize folks are in different places across the sector. We think layered defense, too, to get to that resiliency piece, provides redundancy, also provides that ability to better adapt and recover when you are subject to an attack. So I'm not going to walk through. There's 10 of each. I'm not going to go in great detail through them, but I'll only do this for the essentials. I wanted to just give a snapshot, and it's kind of hard to read. I'm sorry. But if you go to that website, and I'll have a link later in the slides, and we can re-up it. You can download the PDF. Really, we have an interactive feature too, and dig into this. But this shows what I was mentioning earlier, the mapping that we did to the hiccup practices, to NIST controls. So those can be helpful for the more technically minded as you pick these up to see really what do we mean when we say mitigate known vulnerabilities. What are at a more technical level, what does that look like if you apply? That mapping will be really helpful there. We also, again, these are based on our prioritization of the things that we saw when we did that environment scan, that diagnostic across the sector. These are fundamental things that if these 10 are implemented, you'll be in a much better place as an entity within the sector. And I guess, I'll just maybe to illustrate that with one very specific example. When we did that landscape analysis I mentioned, we found that 80% of cyber attacks were identity-based, so things like social engineering, that compromises legitimate credentials kind of to move laterally within organizations. So several of the CPGs, just to bring this fully home, are really, and this is essentials, are built around implementing basic cybersecurity training, email security measures, revoking credentials for departing staff members, relatively low cost, high impact actions that, again, this is not rocket science. I'm sure for those of you with a cybersecurity background, I mean, these are things that people have been emphasizing for many, many years, but we tried to bring it together in a very coherent way that is most impactful for the sector as well. So moving on, and again, I'm hoping to leave time if you have questions about the CPGs. I did want to focus on that last pillar as well, which is maturing ASPR, near and dear to my heart, because that's the organization I'm a part of, as that one-stop shop. So I've touched on some of this already. Again, sorry for the graphic. I know it's probably impossible to read, but this graphic is actually at the very back of the strategy document that I talked about that has these 4 pillars. It is in there if you want to actually go and read it more closely. But the point I really want to emphasize is, while ASPR is maturing as the one-stop shop, that does not mean ASPR is the department's sort of exclusive cyber capability for the sector. We are part of a team. This graphic shows the kind of that spoken wheel where we are the quarterback, the front door, the hub, where we want to provide resources. We do many of the things too. We really do the heavy lifting on incident response, but we have key partners across the department. And we're building this out as we go too. So you won't see listed there HRSA, which is an operating division within the department that does a lot with rural and less well-resourced hospitals, which is where we're focusing a lot with CPGs. So next iteration of this graphic, you'll see HRSA on there too, because they're critical partners. But working with CMS, as I alluded to, FDA, our colleagues in the office, the Chief Information Officer who run that 405D program, as well as some other resources, like they have an entity that provides a lot of technical, they do internal department cybersecurity, but also because of that have a lot of technical guidance and alerts that they develop or amplify from CISA that we can then push out. So it is really, cyber is a team sport within HHS. So part of our role as we mature this one-stop shop is maturing that internal coordination so it's seamless externally. We're also working to expand. I mentioned the 400 plus industry partners that work under that umbrella of the Sector Coordinating Council. We are actively working with them to hope expand that partnership, build and focus in new areas. A key line of effort that we'll be starting with them soon is focused on artificial intelligence, obviously a sort of a sexy hot topic right now, but we want to really dig into what that means from a cybersecurity perspective for the sector and how we can help. So that's one example of where we stand up a joint task force working with industry in that partnership to focus on AI. And I should note, while I'm on that sidebar of AI, the president's executive order on AI has a lot of activity that it outlines for the sector risk management agencies. So that will be a key area of focus for us as we go forward. That uptake of services, that's what I've already talked about in terms of some of the services we provide, some of the services that CISA provides, that we can be the connective tissue to help get and amplify the reach into the healthcare public health sector. Those are areas as we build out this one-stop shop and hire additional people and capability where we'll be focusing. We're looking to have really a robust sort of sector ambassador capability where we have people just going out, pounding the pavement, providing technical assistance, but also just raising awareness of the resources that are available from HHS as well as from the interagency. And I mentioned incident response. Again, change is a good example of that as I walked through on the front end, but really building out the incident response capabilities that we bring to the table is a key area of focus. From an ASPR perspective too, we do incident response for hurricanes, we do incident response in a lot of contexts. We have the National Disaster Medical System, which is deployed in those contexts to do kind of tent hospitals, not necessarily applicable for a cyber attack, but we are looking at what additional tools and resources we can bring to the table to better respond, in addition to just better coordinating the response.
So Brian, a question on ASPR. So when I was in FDA, I was not aware of the existence of ASPR until I got there. And most of my perspective was sort of amazed of how ASPR was serving as the glue within HHS, a lot of internal communications as well as external. But it sounds like the mission is evolving toward helping also to shepherd people from outside government to find the right resources they need. So when would someone from outside government want to contact the HHS cyber team? What are some examples here?
Yeah, so I mean, we are in constant contact with the sector and with industry. So you could contact us if you have. I mean, and really, and I'll get to it at the end. But we have a new email address, hhscyber@hhs.gov, and we're getting questions, any kind of question, really. What are the CPGs? What resources can you offer to help? Historical data questions. And again, we can't always answer all of those, but we're really happy to triage anything. We may not have the answer to all of them, but we want to be that front door. So any question related to sector cybersecurity, we are eager to be able to help answer it. I don't know if that answers your question, Kevin.
Well, I'm trying to think more what some of the audience might be wondering, especially for those who maybe haven't heard of ASPR. Or didn't need to. Maybe they're a medical device manufacturer and they talk directly with FDA on the cybersecurity issues. But I would imagine there are many stakeholders that aren't sure who to call when there's a ransomware attack.
And that's where, so again, we want to be the simple front door. So if you don't know who to contact, come to us. We will route you. If you already have a great relationship with FDA, you work with them on cybersecurity, that is great. Keep doing that. They are incredible partners, and we're not intending to funnel things through ASPR, but when we did that environment scan, it was just a lot of confusion as to what resources may be available, who you should go to. So we did feel like we needed that one-stop shop or front door. But so really, I mean, again, we're like the quarterback routing the questions, helping triage as well.
Okay.
And I don't know if I saw a couple of the questions in the Q&A.
Yeah, we have got some great questions coming up.
Yeah, I can touch on some of those now. So on the EHR question, and there's definitely, I won't touch here the kind of the regulatory piece from the OCR perspective and HIPAA that obviously comes into play potentially if data is exfiltrated from EHRs. But and hopefully I'm understanding the question fully here. But EHRs are a major focus for us in that their lack of availability, if a ransomware attack locks them down to that patient safety focus, it can be really consequential. If you lose access to EHRs and someone comes in and the classic example, they're allergic to penicillin, for example, you don't know that, you give them penicillin, there can be really bad effects. The good news is there's a lot of increasing understanding of downtime procedures, how to go, convert to paper records and navigate some of that, but EHRs are really, really important. In terms of I see the asset inventory question as well. So an asset inventory.
Oh, Brian, maybe you could go back to the slide where you have the essential and the enhanced, because I think that might contextualize the question.
Yes. And on this one, I apologize. I actually don't have a slide for this in this deck on the advanced, which maybe in part informs the question because so correct, there's asset inventory is not one of the essential goals here for a number of reasons, but it is in fact the first enhanced goal. So we recognize it is an absolutely critical step, but these essential goals, we designed them to be kind of the floor, the minimum goals to start. And you could argue an asset inventory is a key piece here, but these are intended to be used by folks who cybersecurity may be their third or fourth job. It could be, a chief nurse in a hospital. So, we did have to make some choices as to how we prioritize them, but they're intended to be viewed together. So as you look at them both, start with the essentials, but certainly move to the advanced as quickly as you can. And we also plan to iterate on these. So we welcome feedback. This is not a static document that will never change. As we hear more, we've developed this in partnership with industry, but as we hear more feedback, we will continue, and we see more activity in the sector, we will update these CPGs as appropriate. So welcome that feedback too. Sorry,
Brian, would you mind if I put up on the screen? I have the essential and enhanced. Do you mind if I just grab the screen for a moment?
Yeah, absolutely.
Let me. So the audience, there was a question from the audience about asset inventory, which is part of the enhanced goal. So You saw the essential from Brian's slides, but here's the enhanced on the right. A follow-up question on that is HHS has actually had, if you look back 10 or 15 years, they've had interesting ways to get technology out. So when actually this brings both questions together. When electronic health records were in their formative stage, this was back when there was actually quite a few outages just from everyday events. Dr. John Homka has a lot of interesting blogs on what happens when his health systems went down at the time about 15 years ago. But it was interesting because with electronic health records, HHS introduced something called meaningful use. And they had stage 1, stage 2, stage 3, and there were incentives, carrots and sticks, to get healthcare systems to use EHRs more and more. And at the time, in talking with some of the Office of the National Coordinator at the time, some of us were joking, well, maybe there should also be meaningful abuse. You know, what about the cybersecurity side as we get things up? So it's interesting as I look at these essential and enhanced. When I look at it, I think, will there be some kind of meaningful use, stages where over time we get to where we need to be? Because it's hard for me to imagine when I teach a course in cybersecurity, the first thing we do is we talk about the threat model and understanding the trusted computing base, and that's basically the asset inventory. You can't protect what you don't know you have. So it just strikes me, yeah, there are going to be a lot of competing requests on resources, protecting from hurricanes, cybersecurity. But it just strikes me like the asset inventory is something that's going to be much more central before you can deploy mitigating, compensating control effectively.
No, again, good points. Welcome the feedback. I would say too, I mean, one of the challenges and one of the reasons, again, we debated essential versus enhanced for that goal. We obviously recognize it's important. You see it there on enhanced. Was the fact that it's not as simple as it may be in other sectors to do an asset inventory in the healthcare public health sector because of, and change is a great example of this, all of that third-party risk, all of the interconnected pieces that may come together in a clinical setting or some other element of the sector. So it is actually, it's a harder activity, we think, than it might be in other contexts, but it is absolutely foundational to your point.
Right. And I suppose we'll see in different elements of HHS, the different agencies have their own sort of specialty approaches. So with FDA and now the new 524B statute requiring SBOMs by law, SBOMs essentially are that, very related to assets, but it's strictly on the software side and the firmware side.
Yeah, and I should upfront note, I mean, everything I'm talking about, these are currently voluntary best practices, standards. They don't obviate any of the mandatory requirements or things that the regulatory parts of HHS bring to the table too, just to be clear. So that's important to note. I see the other comment before I throw my slides up.
Oh, sure.
Or question about proactively identifying a potential attack, common themes. Great question. This is something that we definitely, as I mentioned with the Change Healthcare incident, something that we're trying to do in terms of as we get those TTPs, tactics, techniques, procedures, indicators of compromise, that threat intelligence as the SRMA, we then try to share that. We obviously we don't tie it directly to the victim. We have to do some things, and there's certain constraints on what we can share from law enforcement information or intelligence information, but to the maximum extent possible, we push that kind of information out to then get ahead of other similar attacks spreading across the sector. We see a lot of the same exploits, unfortunately, being used in different places. So that's a big part of what we focus on. I would also note, and this gets to the one-stop shop sort of interagency team piece, while we want to be that front door for the department for HHS, CISA has so many tools that we just don't see everyone in the sector using, that we want to try to push and encourage folks to take advantage of. One of those is the pre-ransomware notifications that CISA offers. So they are often able to detect early indicators of an attack before the damage occurs, before the key information has been encrypted. So just pushing awareness and reach of those other tools, I think, is a key key part of that SRMA function.
Right. So I also think it's interesting on this proactively identifying. There's been a lot of attention on Change Healthcare just because it's so big, but there are plenty of other big systems at risk, and the adversaries appear to be getting much more sophisticated. It seems to be economically driven, go where the money is. It used to be 15 years ago, kids in the basement just having fun. Now it's much more ROI. I would not be surprised if there are business plans in some of the criminal enterprises. But I would imagine there's plenty of other sectors. You mentioned EHRs, but pharmaceutical manufacturing, factory floors, all these systems rely on operational technology, OT, on their factory floors, and in their vaccine and their cold chain pharmaceutical distribution systems. A lot of these systems depend upon the cloud for their logistics, and it's not clear to me where that fits in sort of the what are your assets, what are your crown jewels, and what's being done to not only just look for attempts to get in, but to make sure at least a tabletop, hey, if ransomware gets into our pharmaceutical manufacturing cloud, what happens? What are we going to do? So it concerns me that there's just so much at risk.
Yeah, I mean, the attack surface is enormous. And again, the incentives in the healthcare sector, part of why we believe it's increasingly and often among the top, either the very top of the list or certainly the top three, however you slice the data for ransomware activity, it's because the sort of the perverse alignment of incentives, you're because of that patient care impact, because of those factors, you're really incentivized to pay the ransom, which drives more. Again, it's this vicious cycle. Then if it's the sector that pays or it is vulnerable in a lot of ways because of that, it then sees more of the activity, and we're just trying to break that cycle by building in more cyber resilience with the activities. And again, I'm giving you kind of a wave top of some of what the department's doing, but there's just a lot of energy and activity on this space right now for those reasons. If I can, and I know I'm almost through the slides. I know we're almost out of time too. I want to leave a little more time for some of these questions. These are great questions. I did want to also plug one other thing we've offered, which is relevant to, I think, the conversation we're having about risk right now. And this is the Risk 2.0 tool that ASPR recently rolled out. So there is a Risk 1.0 tool that we rolled out a few years ago, but we recently did sort of a soft rollout in the fall and then have fully rolled it out now. And it is a free capability we offer, online web-based tool that can be used to really sort of look at your own risk. And it kind of, I won't go in a ton of detail to do a demo here now, but it's all hazards. So I should note that, again, with that broader SRMA mandate, it's not specific or exclusively focused on cyber, but it does have a number of elements that are really important here. And two of the key upgrades when we rolled out this 2.0 version that I'd highlight, one of which is very relevant in the context of the Change attack. The previous tool was basically a static spreadsheet that you could take and you could use. And these kind of risk assessments can also help meet other regulatory requirements that you may have to do a risk assessment. So it's a good resource we previously offered. This new one is web-based and can do sort of a system of systems look where you can, if you're a multi-hospital system or you're a different kind of entity in the sector, you can link the different entities and look and begin to see more systemic risk, which again, we see is really important. So it has really a new capability there. The other capability it has that we're very excited about is it allows you to voluntarily share data with us, with the Department of Health and Human Services, not from, again, a regulatory perspective or but in a sort of an anonymized way. We're hoping we'll begin to collect aggregate data on risk across the sector in a way we have not been able to do in a sort of a much deeper dive than the landscape analysis and other things that I've done. So we're really excited if this tool is adopted widely, that we'll be able to have greater insights on where there are gaps, where we can do more to help the sector address risk as it's understood. But you can see here kind of, again, I won't walk through it in great detail, kind of how it's intended to work. But it can develop analytics, visualizations for you. We're building out more subsector components. It's healthcare delivery organization focused right now, but we want it to be all encompassing for the sector. and we're going to be building in. So we rolled this out before the CPGs were final. So we're going to frame some elements of it on the cyber side around the CPGs, some of the new NIST guidance that's coming, those kind of things as well. And again, I touched on some of this here, but I'll just kind of throw this up quickly in terms of I think I actually hit on these already, but where we're going with it, how it applies to cyber. And again, recognize we just have a few more minutes. I teased this already, but that's a screenshot from that Gateway website I mentioned. The link is right there. Kevin, you showed it up on the front end too. So definitely check that out. It's somewhat limited right now, but at a minimum, you'll see kind of a wheel of agencies that can get you to the other parts of the department as that front door. But we will be moving with all due haste to kind of build out additional capabilities. And frankly, welcome your feedback. If you check it out and there's things you'd like to see, you don't see on it, or any feedback on the CPGs, you can use that HHS Cyber email, reach out. We welcome your perspectives and feedback, and we'll do our best to kind of help meet you where you're at and better support the sector.
Yeah. And I imagine this will be a significant topic at the upcoming HSCC all hands meeting. That's where the only regulated healthcare organizations, I believe, is the discriminator, are invited to that, correct?
I think you're talking about the all hands across America.
Yeah.
I'm not entirely sure on the constraints on or what restrictions on participation, but we will definitely be talking about these things there. I know that much at least. We're hosting, the Department of Health and Human Services is hosting for those of you that aren't familiar, that HSCC is under the Sector Coordinating Council. It's that umbrella that with the industry side that we work with very closely. They just rolled out a new strategy for the sector, and they're hosting a all hands across America event, which is I think 7 different locations across the country that are going to all connect virtually, so people can gather together physically in these different locations to talk about these kind of issues. We'll be hosting at HHS headquarters in our Great Hall, the Washington, D.C. Component of that, and are hoping we'll have some guest speakers from the department able to join as well. But yeah, Kevin, I'm not sure on the participation, but happy if anyone has questions about that, or if you want me to get back to you, Kevin, and you can share, I'm happy to run that to ground.
Oh, I would just say for any attendees who are at regulated healthcare organizations, these would be healthcare systems, medical device manufacturers, pharmaceutical manufacturing, but not the vendors themselves. I would encourage you to take a look at the Health Sector Coordinating Council and reach out to them if you'd like an invitation. We'll be hosting one of the satellite events in Boston at Northeastern University, so we'll all be connected in our 7 different cities. But this is at least when I've gone, I usually see CISOs from the major manufacturers and pharma. And if you're not on the list, well, the list is public. So I'd recommend every regulated entity be part of HSCC. So yeah, you're right. We're coming up on the end of time. I do see a few more questions. Oh, I'm sorry. Well, an anonymous attendee says vendors are invited to HSCC all hands. I don't know if that's true, but I would say check with the HSCC website and Allison or Greg Garcia there. I think we maybe have time for just maybe one more question. I want to have just one announcement though. We do have the next CERC coming up on April 18 by David Brumley. He's a professor at CMU, Carnegie Mellon University, and also CEO of For All Secure. He's going to talk a lot about testing, pen testing, and SBOMs and things of that nature in the context of medical devices. And it'll be more on the technical side, imagine binary analysis of software. Let's see. But Brian, you're welcome to, if you see, we have many questions, but I think maybe we'll only have time for one.
I see the one about red teaming related resources. That is absolutely something we're discussing and considering kind of what role we can play in facilitating folks taking advantage of those kind of services. It's not a CPG element necessarily, but it is something that comes up in conversations. And frankly, CISA has a lot more expertise in that area. And a lot of what we do is connect folks to CISA to get more insight on how to select if you're going to use a third party for red teaming. Let's sort of make those business decisions. This is not red teaming, but it's in a way, it's a different way of testing your system. One of the things we do hope to do more of going forward as we build out our resources and capability within ASPR is really supporting a lot of exercises, tabletop exercises with public health departments, with hospitals. CISA has some great resources they provide for sort of do-it-yourself scenarios to sort of game out and walk through what you would do in an incident to prepare for it and build that resiliency. But that's something we want to do more to support the sector with going forward. And one of the, we're trying to use all the levers that the department has here to enhance cybersecurity. One of the other capabilities within the Center for Preparedness here in ASPR is the Hospital Preparedness Program, which is a $240 million grant program, not for hospitals, but for healthcare coalitions within states. And we're about to enter a new notice of funding announcement cycle for this 5-year grant program. And we're building in very intentionally cyber-related elements to include looking at including some requirements for tabletop exercises. So again, different than red teaming, I know, very different, but still a different way to test the system. We'll be leaning into that as well.
Yeah, and I apologize for the many questions we didn't get to, but you're welcome to join the panel discussion and bring that up. But really want to thank you again, Brian. I know you're busy, everything from hurricanes to cybersecurity. Really appreciate your providing the time to talk with our audience today.
Yeah, thanks, Kevin. Appreciate it. And it's not hurricane season yet, so we're busy, but mercifully not dealing with those right now. So appreciate the time. And again, I would encourage everyone, if you have feedback, questions, you can use that general HHS cyber at hhs.gov email. Would love to hear from you, but appreciate your time.
Right. Thank you, everybody. Have a good rest of your day.